meet Arun every year in this instruction course. Actually, mine was a later talk, but I have another session to go. That's why we preponed my talk. So I'll be talking on vertical strabismus. Like Kavita said, treating a strabismus itself sometimes is very complex, and people don't take up pediatric ophthalmology as specialty. And vertical strabismus is a much more complicated situation. Yeah, okay. Let's come. Next slide. Yeah? Okay, thank you. So, as we all know that strabismus is misalignment of visual axis, and if it happens in the vertical direction, it's called vertical. The eye which is going up is hypertropic, and the eye which is going down is hypotropic, and the muscles which are involved in vertical strabismus are the superior and the inferior rectus and the superior and inferior oblique muscles. And these muscles work together, and that's why they called as cyclovertical muscles. If you look at the etiology of vertical strabismus, congenital and acquired. Congenital usually not very common, like you can have a congenital superior oblique palsy or congenital inferior oblique palsy. But then the other causes would be an imbalance in the extra ocular muscle actions. It could be a peretic, or it could be a restrictive pathology, or it could be a muscle which is overacting, like a primary inferior oblique overaction, or can be a developmental anomaly like a craniofacial anomaly, or something which can present as hypertropias. And the classification, it is into two main divisions, the committant and the incommittant vertical strabismus. And you have other causes, like you have the dissociated vertical strabismus, and then you have the the restrictive pathology, you have the thyroid orbitopathy, you have the blowout fracture, you have the Brown syndrome, and then sometimes even after post cataract surgery you have a superior rectus paresis. And then neurological causes, you can have the skew deviation, the infranuclear palsy, and all these are the different types of vertical strabismus. And if you look at the clinical features, they present with the vertical deviation. The eye is either hypertropic or a hypotropic deviation, and the patients complain of vertical diplopia. Sometimes there may be an added torsional component along with the vertical deviation, and they have a typical head posture. This head posture is mainly to maintain bifoveal fusion, which will help the patient to see one and also prevent amblyopia in smaller children. And they have a typical face turn depending upon the muscles involved, and the head tilt and chin up and down. So this is a typical feature of a vertical deviation. And refractive error, usually it's associated with hyperopias, and anisometropia also can be in these children. And strabismus amblyopia also is one of the features in vertical deviation. Like Kavita mentioned about pseudo strabismus, it's very important because child here, is there a pointer here? Okay, you can see the spatial asymmetry in this child. So it is a pseudo strabismus. So in patients where there is an orbital asymmetry, or there is a displaced globe, or if there is injury, facial-maxillary fracture, a vertical angle cloppa, or this side orbitopathy can present a pseudo strabismus. So how do you approach these patients? It's very important to determine the cranial nerves and the extraocular muscle involved. For this, you have to take a detailed history regarding the onset. If it's an acute onset, or is it following trauma, or if it's constant, is it intermittent, and is there any associated diplopia? Very important, another acute onset is sometimes we have seen like space occupying lesions, or even like cystosarcosis can present with an acute problem. So you have to ask the history, really probe and ask. And then ocular examination, you do an orthoptic evaluation and special tests, which I will be talking about later on. And neurological examination also is very important, because some of these vertical muscle palsies can be associated with underlying neuro or cranial pathology. Then orbital ultrasonogram, an imaging CT and MRI is mandatory in cases which are indicated. And the FAT test, the photo album test we popularly call, is mainly because the parents will complain that this problem is only for the past 1 month, but then if you review the photographs, you can see that the child will be in a group with a small head tilt or a face turn. So that's very important when you want to diagnose a vertical strabismus. And always look for underlying systemic diseases, mainly thyroid, which can cause vertical strabismus. And then external examination is very important. Always look for facial asymmetry, and do a detailed examination of ptosis, lid retraction, and then the injection of the recti, mainly to rule out thyroid problems, and then any other orbital dystopia. And how do you identify the muscles involved? Mainly with the abnormal head posture. Predominantly, if there's a face turn, it could be horizontal recti. If there's a chin up or chin down position, it could be a vertical recti or a pattern strabismus. And if there is a head predominant tilt, then you will think of obliques. And coming to the evaluation, it would be a motor evaluation and sensory evaluation. motor evaluation, I'm not going to the details because Kavita already spoke about the different types of cover tests and the measurement of deviation. But what is important in a vertical deviation is the Parkes 3 test or the Belchowski's head tilt test. This is mainly to find out which muscle is involved. So you primarily put the patient in primary position and look at the eye which is deviated, and then you will narrow down to 4 muscles. Then you ask the patient to look to the left gaze and the right gaze, and then you narrow down to 2 muscles, and then you measure the deviation with the head tilt on right and left, which will help you to find out which muscle is involved. And then the other tests which we already mentioned, and then most importantly the diplopia charting, the Hess charting, the Maddox double rod test, and the binocular fields of fixation, and the fundus examination of torsion. These are the very special tests which are meant only for vertical strabismus. So always when you check for the motor evaluation and sensory test, you check if the patient is able to fuse the double images prior to surgery, because it's very important for your diagnostic and prognostic value. And also if a patient has got a diplopia and if you're not able to judge, it is better to put them in adjustable sutures. And these are the sensory tests which you use, the fourth 4-dot test, the Baglioni glasses. The synoptophore can be used if you have an access to synoptophore, and after image test. These are all tests to evaluate the sensory status. So this is the diplopia charting. This is horizontal muscle. I have another picture for the vertical muscle. So this is a recording of the separation of the double images in the 9 positions of gaze. So this is the red and the green, and then you can make out the maximum separation. So this is a patient with the left lateral rectus palsy. Needs a lot of patient cooperation, so it cannot be done in uncooperative patients. And this is a dissociation, the Hess chart test with a haploscopic principle, and this mainly depends on the foveal projection, and it follows the Hering-Saw and Sherrington's law. And this was, this test was formed by Rudolf Hess, and this is very helpful. And you compare the fields here. You have the red-green goggles, red in front of right eye. You can make out the 2 fields. The smaller eye is the peritic eye, and then you look at the underaction of the muscle and then the overaction of the muscle. So this again is a case of if you see the smaller is the peritic eye, so the right eye is a problem. And here you can see that there is the limitation of abduction. So the lateral rectus is a problem. So this is a very helpful test to find out the muscle which is overacting. The other special tests in video, can you work on the video please? The other special test you would do is a forced action test, especially when you want to distinguish whether it is a mechanical restriction or a weakness of the muscle. So you put a drop of topical anesthesia, explain to the patient about the procedure you're going to do, and then you do the pull the muscle and see if there is a mechanical restriction. The other test would be the force generation test, especially when you're taking up for surgery. You find out whether there is some action in the muscle. So that will indicate whether you can operate on those muscles. So that is force generation test. So I have a few case examples which I am going to show. This is a young man, like 40-year-old man, who presented to us complaining of double vision following trauma, and this is the diplopia chart. And he had 8 prism diopters of L/R, which increased in right gaze and left tilt, no fundus torsion, no inferior oblique overaction, and you can see here. You can see here that the left eye is the peritic eye. You can see the underaction of superior oblique, and you can see the overaction of the inferior rectus. So the diagnosis of left superior oblique paresis was done. And this is just to show you the algorithm of how you go about when you treat a superior oblique palsy. So if they have absent tendon, you will do a recession of the superior rectus or weaken in the inferior oblique. And if there is a marked lax tendon, you either go in for a tuck of superior oblique or weaken the inferior oblique muscle. So if there is an inferior oblique overaction, then this is what you would do. If there is less than 15 prism hypertropia, then you weaken the inferior oblique. If it is more than 15 prism diopters of hypertropia, you would either recess the superior rectus or weaken inferior oblique. If there is no restriction, then go in and recess the contralateral inferior rectus. And this is for the if there is no overaction. And this particular patient had a right inferior rectus recession of 4 mm adjustable sutures, and he looks orthophoric. The second thing would be a Brown syndrome. The superior oblique tendon sheath syndrome can present as vertical strabismus. You can see very typically the elevation and adduction is restricted in this child. It could be acquired or congenital, and very importantly, you have to again do a imaging for these patients to rule out any other cystosarcosis cyst or something which is causing this. And then treatment wise, you can, if there is any inflammation associated, you can treat them with steroids. or you wait and watch, because now the two schools of thoughts, one you go and operate, the other one says you wait and over a period of time, these children get better. So that is what you should keep in mind. And then dissociate vertical deviation. Very typically you can see the eye under cover comes down. I don't have a video with the Spielman's occluded, but ideally it will be good to check with the Spielman's occluded. You can see or appreciate the video better. So these are dissociate movements where both eyes go in for hyperdeviation. And what do you do for the DVDs? Depending on the presentation, if there's an inferior oblique overaction, you would plan for inferior oblique transposition, or you would plan for a bilateral superior rectus recession. It could be asymmetric depending on the presentation. And Duane's retraction syndrome can present as hyperdeviations, especially with their upshoots. And thyroid orbitopathy is one of the major causes. You can see this lady with the proptosis, the starey look with hypertropia here. So when you have patients like this, you have to check their thyroid profile, work with the endocrinologist, and then try to reduce their thyroid parameters. And then if there is an associated inflammation, again imaging is mandatory in these patients. If there is any inflammation, you can treat them with steroids, sometimes radiation, and then once you debulk the eye and then get it to normal, then you can think of surgery. So she had an inferior rectus recession, but then invariably after some time they go back to the original position. So one thing is during surgery you have to be cautious, because it's a fibrotic muscle. Thick muscle is inflamed. Sometimes the chance of losing the muscle is also very friable, so you have to keep that in mind. And my last patient is a patient, it's a very rare case, not many reports seen, hardly about 15 to 20 reports seen. This boy presented with the abnormal head posture since 4 years of age, and then on examination he had 30 prism diaters, he had obvious head tilt, and then his right tilt was 35 prism diopters of R by L. You can see here the right hypertropia, the left tilt was 16 prism diopters. So diagnosis of inferior oblique palsy was done, and then he had a posterior tenectomy of the left superior oblique, and the right superior recession with adjustable was done, and this is how he looked post-operatively. So vertical strabismus, again we should not forget to talk about the pattern deviation. The A and the V pattern deviation can be associated with the vertical strabismus. So vertical strabismus is not as difficult as we think, but then what is important is before you take up the patient for surgery, does medical treatment have a role? Yes. If it is a deviation less than 10 prisms, you can always try prisms on these patients, and then orthoptics can be tried. And when you take these patients for surgery, it's very important to measure both the horizontal and vertical and torsional components. You can always take fundus photographs to see the torsion, also to measure the torsion and to also judge your results after your surgery, and do a prism cover test for horizontal distance and vertical torsion measurements, and scanning and imaging we already talk about. So you all do if you do all this, then you will definitely get good results, and it is not very difficult to manage vertical strabismus. And thanks for the opportunity.
Thank you, madam, for the excellent presentation. Do we have any